Okay, let's go ahead and get started. Sit down. Okay, well, thank you everybody for coming to Talking Public Health. We've got seats up front for those of you hiding in the back. Sandra's leading the way. She's not. Then Leah and Karen can lead the way, sitting up front. Okay, so very pleased today to have Abby Barker with us. Dr. Abby Barker has a PhD in economics from the University of Minnesota, which is quite impressive. Economics, I'm impressed. and Abby is an associate professor in the School of Public Health, and we're thrilled to have her do her talk today. Her research focuses on economic modeling and microsimulations on topics related to health insurance markets, Medicaid payment policy, and health reform. She also studies nutrition and food policy from an economic lens. Her ongoing work for the Rural Policy Research Institute focuses on understanding how markets can be successfully integrated into the healthcare sector, using data from the Affordable Care Act, health insurance marketplaces, as well as Medicare Advantage. Particularly, Dr. Barker also has a significant role in the Missouri Medicaid Office of Transformation, where she helps the state implement value-based strategies across a range of efforts, including maternal health, rural population health, and hospital payment. I call her the guru of Missouri Medicaid, at least for us. She is also the Associate Director for Policy Partnerships at the Center for Advancing Health Services, Policy and Economics Research. So it's really, really exciting to hear Abby talk. I've worked with her before and she does some amazing work. And I'm going to turn it over to her to highlight some of that.
All right. Thanks so much, Deborah. So my talk today will be much more in the policy lane than in the research lane. And you'll see as it goes that there's kind of an overarching theme here that is, I want to get us to a place in Missouri where we are even set up to be able to do research on some of the topics that we're really challenged by. So by the way, sorry for the very plain label slide deck I have here. I am not creatively inclined when it comes to graphic design. So a little bit of background. As Deborah mentioned, I am a consultant to MoHealthNet, which is what Missouri's Medicaid program is called. And I've been in the Office of Transformation since January 2020, shortly after that office was created. It's an office that approaches Medicaid reform with a lens of cost effectiveness. So, you know, the economics background is helpful there, but really in a little bit more of a broad kind of context, thinking about upstream solutions and how we can focus on them. Like that's actually really the key to thinking about cost effectiveness in a serious way. We look to design policies that recognize what I think of as a more expansive concept of value. You know, the term value-based care, value-based payment. Sometimes people look at that or think about it in a very financial kind of way. But to really understand what value means, you know, you're talking about quality at the heart of the equation. So leveraging value-based payment models to drive improvements. So today I'm going to be talking exclusively about some maternal health work, but a lot of these concepts apply to other work as well, especially in rural health. That's a whole nother topic. So just a couple of quick background slides. Probably most of you in the room are familiar with where Missouri sits in general, if not specifically in maternal health. We were in 2023 ranked 43rd among the 52 Medicaid programs in our percentage of low birth weight babies. And not that that's the only indicator of maternal or infant health, but it is kind of one of those key indicators that everybody really looks at. And, you know, it definitely has strong associations with other bad outcomes. Some other statistics coming from our Pregnancy Associated Mortality Review Board that puts out a report annually or biannually. The population served by MoHealthNet was about 2.8 times more likely to die of a pregnancy-related cause than those who had private insurance. Similarly, among pregnancy-related deaths caused by cardiovascular disease, 58% of these cases were Mo Health Net participants. And for context, we pay for in Mo Health Net about between 40 and 42% of the births of the state are being paid for by Mo Health Net. So 58% is definitely disproportionate. Only about 55% began prenatal care in the first trimester. Among pregnancy-related deaths caused by mental health conditions, 59% of those were Mo Health Net participants, and only about 62% began prenatal care in the first trimester. And generally speaking, the 55 to 60-ish range, that's something I'll come back to a little bit later in the presentation as something that we have some goals set to try to improve. And so on that note, I just wanted to kind of explain the overarching desire here when Mo Health Net kind of started to convene a bunch of people internally in the agency and some external partners and think about how can we do something about this? Like, how can we do something about these really bad statistics? And those represent people, the women who are dying, women who are experiencing severe maternal morbidity, low birth weight babies that need a lot of extra care. They stay in NICUs for months, all of those things. And we wanted to add programs and adjust policies. But I think when you add a program or you adjust a policy, you're sort of by definition working a little bit around the edges of the problem, that you're going to have some marginal impact. We wanted to ensure we had a unifying structure that would hopefully automatically be at scale. So when I mentioned the 40%, that translates to over 30,000 births per year. So how do you figure out a way to try to strategize and encompass hopefully all of those, as many of them as we can? And so that's the second bullet is mentioning, the systematic approach is necessary because we need to have something that does well at a statewide scale. There are lots of little programs that do great work, but they do it in pockets and they serve 200 people here and, 500 people there. But this is the apparatus of the state, and the policymaking should try to encompass as many women as possible. And so on that note, our previous policies, still today, we do rely on managed care organizations, MCOs, to try to assist women on Medicaid with navigating their care, right? That is the mechanism that the state has chosen. And for some people in the room who have that familiarity, you might not necessarily be all gung-ho for MCOs or not. Like there's kind of a perception among clinical providers in the state that's kind of a not always the best way to go about trying to get personalized care, to kind of trust a large organization with that. And I think to that point, there were lots of ways for individuals to remain disconnected from MCO assistance. But from the state agency perspective, we would hear the managed care plans talking about all the different things they offer, and it sounds really great. And they would tell these nice stories, and it would sound actually really good. Like, how do we kind of connect those two different, very disparate ideas about what the possibilities are for managed care? Because of that little subset that are being helped, they actually do seem to be quite helped. Like it's not like they're lying. But on the other side of it, when you ask them, like, well, how often are you engaging? Like, how often are women actually saying yes to care or to assistance, to care management? Well, those rates are pretty low. And then you have to unpack why. And I'll get into that a little bit in a minute. But the assistance is also a little bit limited by available resources. There's a lot of structure in place about what managed care can spend money on and what it can't. So I'll say a little more about that. And then when I say unclear incentive structure, it's a little bit of a code for like the way the rates are set up and the fact that in Missouri we have 3 managed care plans. They have a competitive rationale, I guess, for decision making. And so all of those things, without really getting into too much detail and unpacking all that, it created an environment where I think that the whole issue was kind of stagnant. There wasn't a lot going on. So enter the economist who is a data nerd. And I was pretty amazed, not in a good way, when first came to this topic within the agency to find that they really had no knowledge of almost anything in terms of their ability. Sorry, that came scratch that from the record. They had no real good way to have a data picture of what's going on with their participants, with their members, and especially the risk factors experienced by pregnant women prenatally, and no established way to link prenatal claims of a mom to the claims related to the baby's care. So, like when you think about trying to have a model of cause and effect, and you want to think upstream and you want to influence these bad outcomes down here, but you actually have no way to know what happened over here, you are in the dark. Um, After much negotiation, like lots and lots, and it started before I even got there, and I'm not claiming any credit for achieving it. But an agreement was established, maybe a little tiny bit of credit. An agreement was established between our agency, the parent of MoHealthNet is Department of Social Services, and then the Department of Health and Senior Services. They are the ones who hold the birth certificate data, vital records and statistics, so that those birth certificate records can be used to establish the linkage so that we can actually see, and I think our linkage rate is about 87%. We think most of the ones we can't link are situations that like the baby's being born in a different state, because Missouri is bordered by 8 states. So that does happen. Longitudinal mom baby records can be created for the first time. So that was a huge victory. And it is key to a lot of what I'm going to talk about next. So we launched, so with that background being said, we also really needed to understand the risk factors of each and every pregnant woman. So we created a new data collection tool. It's called the Notification of Pregnancy and Risk Screening. Had a soft launch in November of 2024. It was developed over the course of a year, and really that form replaced 3 separate forms that were used by the MCOs. So imagine if you're a clinical provider of OB services and you got 3 different forms to work with. This one's supposed to be uploaded to a portal. This one they want you to fax. This other one, you can email. And it's just like a piece of paper that you're filling out essentially. Those are not data fields per se, right? And so they're just forms. They're mostly collecting some clinical history. But they had, oh, here it is. The prior forms had included free text boxes. So it's basically like, hey, I want to send a message to the potential MCO case manager. I want to let you know that this is going on with this mom, which is good, right? That's nice. But it's really a one person at a time kind of piece of information. And so what we did instead was we standardized the form. It collects both clinical and social risk information in a format that is actually being uploaded. And we actually have an online portal. So even though there's a paper form, which I'm going to show you on the next slide, that's just it's optional for collection of the information, but actually all the data automatically goes into a portal, which, turns itself into an Excel sheet every day. And Medicaid is reimbursing providers for filling out the form. So we are essentially paying for data. We're saying we value this data. You are the provider at the point of contact with that mom. You have hopefully a relationship with her of some kind, or you can build one. And part of building one is to acknowledge, the whole person. Like, okay, here's your clinical risk factors, but tell me, do you have enough food? Are you worried about whether you are going to have enough food? A whole set of about 12 questions on the social determinants side. And then again, thinking in terms of data and potential for future analysis, we built the claims process so that the provider has to put the Z codes that are relevant to those SDOH issues as they occur. And I'll explain a little bit more about why, what we can do with that. Anyway, keeping on going here. Okay. So the goal of the notice of pregnancy, you're not meant to be able to read this, but you can just kind of see that there's a form. Starts out with demographic and contact information. Then we have a clinical history section, and then here's the social risk factors section. So we intend for this to be administered by maybe a community health worker or a social worker or someone in the provider office that can actually have a little bit of a conversation with the mom. There's also an intent that the person who's doing that screening, if risk factors are identified, they're going to say to that mom, hey, you know what? You have a Medicaid health plan. When I submit this information, someone will reach out to you. Someone will call you and offer you some special, assistance and support. And so that kind of warm handoff is also part of what we're still working on, to be honest. But the goal is timely and accurate data from providers, leverage existing MCO contracts to hold them more accountable for following up on documented needs. And I can't emphasize enough how important that is. That gets back to the Z codes. For example, over here, you can't read it, but this says lack of reliable transportation to prenatal visits and other activities to support a healthy pregnancy. And there's the Z code here, 59.82. Now, if that has been coded, if we can see it in our data, then we can do analysis on it, right? We can say, how many women had transportation insecurity? What does their prenatal claims history look like? How much did they get? Did they get enough? What did their birth outcome look like? You can start asking a lot more questions if you have data. And so that is also something, like going back to what I said was saying here, you can build in expectations for the managed care companies about responding and how fast they need to respond. You can't do it if you can't see it, right? Identify additional evidence-based and informed solutions to address particular risks. And I'll say more about what I mean by that. But again, in a data environment in which they can be evaluated. So that's really a critical piece to this. All right, so I'm going to show you some little tidbits of data off of the NOP. First, I'll just orient you to what I'm going to show you by saying that we had a consensus building set of meetings that went on a long time among clinical experts at Missouri Medicaid and at the 3 MCOs. We all kind of agreed on what needed to be on the form. The purpose of the form is to be a snapshot. It is not an all-encompassing, complete set of knowledge about every single thing to do with the clinical history. We agreed on a scoring rubric for the risk factors identified on the NOP, and so that places a score from 0 to 100. And then you can see the risk categories that we assign based on points. And I'll just note that we did have kind of an automatic qualifier. Certain types of pregnancy or certain history automatically catapult someone into the 50 or up range. And so you'll see in the data in a minute how that shows up. So just to kind of give you a sense of how this data collection has been going, I think I would characterize this that maternal health care providers were pretty darn excited. They really felt like this was something missing and that they were willing to make an effort to start to do this. They really liked the fact that the 3 forms turned into 1 form. Now they had some adjustment they had to make workflow wise. Not everything just is, it's not just so easy to flip a switch and all of a sudden you're doing a different thing than you were before, especially if it's a bigger facility. So we did have 3 pilot providers. And so you'll see this line that says soft launch. All of the data prior to that was 3 pilot providers. We had SSM here in St. Louis, we had University Health in Kansas City, and then we had Freeman Health System in Joplin. So we did have one that was a little more rural. And Freeman had an easy job implementing, right? Like they just go down the hall, be like, hey, guess what, guys, we're going to do this. And it was pretty easy for them. SSM really took forever. Like they actually had to rework lots of things across multiple organizational units. Like it ended up being very complicated. Anyway, you can see that then we had a soft launch November, and then as a statewide implementation, what that meant was that at that point, you could not use the other forms. Like all the MCOs said, we're all using this form from this moment on. And so you can see the volume from then is kind of hovers around 500 to 600 per week. So if you think about back when I was saying at the beginning, the goal here is like systematize this. Like we are getting all this information in. So on the back end, what is the state doing? We pull in, not me, but the Excel spreadsheets that are getting generated, they get routed to the MCOs. They have contract expectations about how fast they address um, do the initial outreach and try to work to connect with the moms and address those needs. Um, so that's where we are. We had soft launch, or we had pilot period, we had soft launch, and then from statewide, just in the last week, we exceeded 30,000 NOPs so far, cumulative. Okay, so this is a little bit of a weird picture, and it's a little hard to see what I'm driving at here, but essentially what I'm trying to say with this slide is what we're used to thinking of with pregnancy is a clinical risk score. Like that's very common. That's been done for decades, right? What we're not so used to is the idea that you need to kind of think of another axis. There's an axis of social risk, and here it's called sociodemographic risk. I'm pulling a couple things off of the age of the mom, if it's very, very young age, very older age. There's a couple demographics on there too. So like think of 50 points of sociodemographic risk and 50 points of clinical risk. And if you, I lost my, my legend. So green was that low risk category. Yellow was moderate risk. Orange was high risk. And then red was very high risk. And so you can see, like there are some people who hit that, they hit the automatic, automatic trigger into high risk. But what I really want to point out here, and the circles are the size, the number of NOPs that we've seen, so the bigger circles is a greater volume. But like if we look at someone like, like this, so the provider might have assessed the clinical risk and thought, okay, well, there's a moderate amount of risk there. But without having this tool, we don't know that she actually has like 38 points of social risk. Like, how does that compound the problems that are likely to be faced by this individual? So I've used this graph over and over, really just to hit the point home for the managed care plans to make sure they're understanding the new opportunity that they have with the data that they're getting in spreadsheet form. So the next slide is going to be, I'm going to interpret this one for you too. Another one of the goals that we had here is, the idea of earlier initial knowledge of the state and of the health plan that somebody's pregnant. So I cut this from March 1st because really we had most providers had started to adopt this by the 1st of March. Like almost all providers had kind of gotten going on it. And the data is a little wonky at the beginning because they were submitting NOPs even for women who were already 5 or 6 or 7 months pregnant. They had already seen them before. So it wasn't really, it wasn't a good measure of initial contact. And so this is just a box whisker plot. So, you can kind of eyeball this. I can't say that I have like a statistical way to prove this, but what I'm looking for is for, at this point, we've got 75% of the women being seen having their NOP filled out prior to 17 weeks. So that's where we are now. 17 weeks corresponds to 4 months. And as I'll say in a minute, there's kind of a well-known standard for prenatal adequacy. It's called the Kotelchuk Index. And the necessary criterion for that is to be seen prior to 4 months. That's the first of 2 criteria. And so like ideally, we would love to have the entire box with the whiskers be below 17. We're not there. But you can kind of see that like the box is trending down. And that's what we want to see with this program. We want to see that more and more moms are coming into our sphere of knowledge and potential influence earlier in the pregnancy. And I think that's what we're seeing. So I keep monitoring this diagram, and every month I pull the new data in. So this is up to the minute. This is like as of September 30th. And you can see, I feel like it's good progress over time. And you can see the median has dropped to 11 weeks, which is, I think that's pretty good. So, one more, I think, on the NOP data. For those of you who are dissemination and implementation specialists, this one's for you. We have more to do for sure. So this is a map of where NOPs are coming from. You can see they are coming from everywhere throughout the state. Everybody's doing NOPs. Yay. We have a lot of NOPs coming from obviously our urban zip codes, but really there's some hotspots in some rural areas too. Cool. Okay. But here's the number of NOPs that show any positive number on that social risk scale. Now you saw that other slide a minute ago with the big green circle over in the 0, 0 axis, and were you kind of suspicious? Yeah, you should be. Um, there, there are people who are still thinking of this as just a form. They're like, it's just a form. The state wants this form. I don't care. So they're going through the motions of the form, but they're not providing good information, we think. And so you can kind of see that here, because I don't believe that, right? Like, I don't believe that in some of these zip codes where they are filling out the form, no one has a social risk factor. Not what I know about rural Missouri. That's all I'm going to say. So, see me afterward if you have great ideas about this. We are, there's a provider education unit within MoHealthNet. They continue to work on this. I actually have a tab in my Tableau where I drilled down by the email address of the NOP submitter. And then I gave a list to the provider education woman. And I was like, do you want to reach out to these people and ask them if they understand? Because they were just constantly filling out the zeros. It was all zeros all the time. I was like, this is just not. Okay. So what are we doing now? We are designing targeted policies and programs that try to address many of these risk factors, these drivers that we're seeing on the NOP. So I can talk a little bit about most of them, I guess, a few of them. So group prenatal care, we actually implemented in December. So it's an enhanced reimbursement. So it kind of tries to compensate for the extra effort that it takes to do a group prenatal kind of model. We launched that in December of 23. And I will say that was kind of a little bit of a success story in terms of kind of bridging the research to the policy and the practice, because I was aware of it because we had a maternal health policy event, our center did, back in 2020. We had Dr. Ebony Carter participate as a speaker. Many of you in the room might know that she had an NIH grant doing her own version of group prenatal, wildly successful among Black women in particular. So invited her to come give a presentation, virtual presentation to a number of state colleagues. And people were like, yeah, let's do this. And it was actually really one of the easiest policy things we were able to accomplish. Now, we don't see a ton of uptake yet. So there's a barrier there. Doula services, we got that reimbursable and live as of October. So it's a 1-year anniversary this week of getting that out there. Again, there's hiccups with that. Turns out it's really hard to bill Medicaid if you're a regular guy. So there's a little bit of challenge there, but I think when you think about this from the perspective of the MCOs, that's the mechanism we have, right? We're feeding them data now that says, okay, here's some risk factors. Here's what's going on with these moms. If you can get a hold of them, if you can talk to them about their situation, you can do things like offer them a doula. If you think that's something that you would recommend for a particular situation. Now, you don't need to have a recommendation. Anyone who wants one can find one, but it's a tool. I think of it as a tool in their toolkit. It's telling them, here's some things you can do. Medicaid will pay for. Perinatal home visiting. I know a few people in the room that might be pretty excited about this one. This is something that's just now getting launched, like right now. And that is entirely based on the NOP. So the NOP data, if the mom is under 20 weeks pregnant, gestational weeks, and she has a high level of clinical risk, or she has any score of clinical risk, but she has indicated on her NOP that she lacks support of family or friends to help with the pregnancy or the baby, or if she indicates a risk factor related to domestic abuse, those are automatic qualifiers. So those are going to be the qualifying conditions that will have the MCOs reimbursing for home visiting. It's our perinatal home visiting. It's going to include standard home visiting, also nurse-based home visiting, kind of a preference for nurse-based if the mom has a high clinical risk profile, but really whatever she wants. So that's coming along. We have a nutrition education program working with University of Missouri Extension. We have a 2-year study going on now that also just launched, where if the woman is 20 weeks pregnant or fewer and has indicated food insecurity on the NOP, then this program is offered. And that program is a series of 6 classes, virtual cooking education, kind of cooking classes that are, they're virtual, and it's coupled with Walmart grocery delivery of the food box of items that are necessary to make that recipe. And then when the mom completes the series, she actually also gets a Walmart gift card as a further incentive that she can use for, well, hopefully something cooking related, but it could actually be whatever. So that's a program that's actually kind of it'll be a study that MU Extension does. I mean, I'll be participating, kind of being able to pull some of the data, but really hopeful that that will show some interesting promise, and that, ultimately could be scaled up to be more of a permanent, always there kind of option. Linkage to C-STAR providers for SUD. So there are some SUD questions on the document. Again, like thinking about systems and the fact that we often have these silos of different entities that don't communicate with each other. So C-STAR services are through the Department of Mental Health, which means that we don't really totally know what's going on there all the time, and the managed care companies don't for sure. So using the NOP to that opportunity, if someone has marked that there's an SUD concern, we can bump that up against our claims and find out whether that mom is already engaged in C-STAR services. And then if she's not, we will let the managed care plan know that that's an opportunity. Managed care management services. We actually, there's pretty good evidence out there that those services do work. They are helpful when someone gets them. So this is our data from through the end of May. There's 2 places where people drop off in particular. First, you don't even get a hold of them, right? And in this day and age, it's because they don't recognize the number. Okay, so one of the reasons one of the reasons that we have that warm handoff concept at the doctor's office is we want the doctor's office to say, oh, you have Hope State Health, you're going to be contacted within the next few days. Now, side note, I will just comment that when we first were talking through this, I said to all 3 of them, what shows up on the caller ID? And they were like, we don't know. I mean, so look at this number. This is their usual successful contact rate. This is how many people answer the call, much less engage. So they answer the call 29% of the time, willing to engage in services 17% of the time. And that's among the successful contacts. So you have to multiply those together to find out how many people are actually getting the service. So we did fix that. They now all have caller ID information that you can understand. So that's good. In the pilot, we had really involved pilot providers. They were so gung-ho. They were really, really passionate about making this work. So the successful contact rate in the pilot was even better than it is statewide so far. So, some of the providers, like I said, they don't totally get the whole point of this. But still, it's way better, right? It's definitely way better. And then the rate of engagement in services has just gone up and up and up. And at least one of the managed care plans has, as in their words, they flipped the script. So they use this as an opportunity. They lead with the SDOH now. So the way that they used to approach talking to these potential, these members, potentially trying to engage them, rather than starting with like, let's review all your clinical risk factors and problems and, think about what you should be doing better for healthcare. Instead, like, oh, I saw on your form that you're worried about food. Like, let's start by helping you with that. And so they completely, and I think that I think that the fact that it got even higher, like that, I think that this increase here is at least largely driven by that change, because that health plan has the best numbers. And then other managed care specific interventions and engagement, they are 3 different plans, so they can also kind of go off and try some of their own things, which they do. I think I'm good on time. So last couple of slides are going to be wrapping this back up in terms of the themes I mentioned at the beginning: value-based payment, and really opportunities to push more money upstream so that we can do more upstream now that we have these data. So with the linked mom and baby longitudinal records, we implemented a modified Kotelchuk index to score the adequacy of prenatal care. The index considers both early initiation, no later than the end of month 4, and then also quantity of visits throughout the pregnancy, and that is relative to ACOG guidelines. If you don't hit at least 80% of what ACOG would recommend, then that's also inadequate. So the state implemented a bonus payment for MCOs in January of 2025 to drive improvement in this PCAI. And the logic here is we want them to use that to address transportation issues, which, remember, they can now see in their claims, hopefully. And engage with partners. That might be clinical partners, that might be strategies, within specific clinics that have high volumes, that, transportation insecurity, like they could put it on a map. They could say, well, here's our hotspots of problems. They could go work with the state's transportation broker, and they could say, hey, like, let's really figure out how we can prioritize pregnant moms, because like this is the high priority population. You might also work with doulas. Like, a lot of times doulas, part of their role, they will see their role as accompanying moms to their prenatal visits, kind of helping be that bridge and make sure that she's getting all of what she needs to take away from a visit. So, I mean, if she's involved in that role anyway, then, that can be part of that as well. And then one more, which we hope will be even more impactful, is a second value-based strategy that rewards MCOs for improving their rate of healthy birth weight babies. So saying it the opposite way to be positive, but that's also lowering the low birth weight rate. They have a lot more flexibility in spending their money on preventive and upstream services than like the fee-for-service program does, where we're always behind the 8 ball. We're always waiting until something bad happens and then we pay the bill. The managed care plans, like part of the beauty, the logic of that model is that they can pay for more things kind of at their discretion. So they can fund community partners, any other kind of creative strategy they might come up with to mitigate those social risks, that they can implement something. And I think the kind of tying it back together, our work on this NOP process and the related policies and programs has provided the MCOs with a whole bunch of tools in their toolkit that they did not have before. And so those were the lack really put them in a situation where they were being tasked to do something that they didn't have the data for, and they didn't have. I mean, they had the flexibility to, like, one of them on their own could have done a really cool thing, paying doulas for lots of stuff, or, whatever. But when you're one of 3, it's really hard to step out in front of or aside from your competitors and do something really great, because you actually will attract more of the high risk people to your plan and you won't get any credit for that. So that's what I meant, like at the beginning, when I said there's some kind of questionable incentive structure. So this, with these value-based payments set up the way they are, it really gives them an incentive to go ahead and put some money towards something. This payment is potentially really large because it's indexed on the difference between what the state pays for a healthy birth weight baby on average mom side, baby side, and a low birth weight baby on average, which is tens of thousands of dollars difference. So there's a lot of latitude there, I think. And I guess I'll conclude by saying I do recognize, as many of you in the room have probably been kind of noticing along the way, there are tons of research questions in here. Like, I think all of this work so far has been setting up a landscape, a structure that provides enough data to even begin to try to answer them. So if you were looking for a heavy duty research talk today, sorry, you did not get one. Maybe want to come back next year, there might be something to say. Obviously, it takes 9 months to hope to see some improvements based on these strategies. Nearly all the OB providers in the state were submitting these NOPs as of March 1st. So you can kind of, work from there. Like, it should be by the beginning of next year, we can start to put these pieces together. We can analyze what works and why. You can do some multivariate modeling if I can get the MCOs to provide certain data. And then my agency colleagues continue to work on provider education, on the importance of good data. We also want to bring more LPHAs into the work. There are some that participate, some of the ones that offer some, pregnancy testing and stuff like that. And they often see a mom for the first time 4 weeks on average before she gets into an OB clinic. So that's 4 really valuable weeks. So we're working on that. Still need to do more. I also just want to mention, like, there's one current grant with a School of Medicine colleague that is already leveraging the NOP. Funny story, like, she was trying to make up what was kind of like a sort of an NOP as part of her grant. And she brought me on to say, like, oh, we want to make sure we're doing this in line with, there's always that sustainability piece that's why people come and knock on our door at our center. And when I looked through her stuff, I was like, oh, you should probably know, like, we're doing all these things and this is about to go live, and kind of filled her in on the policy landscape. So she was able to kind of recraft her grant to be tailored to this, because it's perfect. Like, the sustainability of it writes itself. And so it's really, it's pretty cool. So I guess stay tuned. Like I said, I don't have a ton of results. Other than just kind of visual results. But I'm pretty excited about the potential. So there I am.
I appreciated learning more about this, and I appreciate the attention you're bringing to the importance of data and data quality. And I wanted to know, on the topic of high quality data, sorry, I'm losing my breath. I'm pregnant. Uh,
How
have,
appropriate.
yes, so I'm interested now. I'm like more interested. But have you considered, when I saw the questions, some of them seem to be highly stigmatized, and especially like substance use. And there's a lot of fear that, your kid will get taken away from you, or there's going to be surveillance, contact the police. So is that part of what you're thinking in terms of provider education, in terms of building relationship?
Yeah, absolutely. And thanks for bringing it up, because I think, even though I kind of took the tone that I'm kind of annoyed that the data aren't better, and I do think that in some of the cases, it is providers not really understanding that we're trying to create an opportunity to help people. But I also think it's what you said. Like, I think that the providers haven't quite figured out how to um, I don't know, train the right staff or have the right workflow so that they actually have the time to engage with each mom coming through, and not making it seem like, I'm just going through this form, check, 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 check. And that's not an environment where people are going to want to disclose sensitive information. And so I do recognize that a lot of the kind of the false zeros are probably coming from that kind of situation. And I think our strategy is just to work toward making sure people understand that this is a meaningful communication that you as a provider are making to somebody who has deeper pockets than you do. And also recognizing that, like, at the end of the day, maybe someone doesn't disclose that right off the bat. But if they do get in with with a case manager, or even if they don't want a case manager, but they do accept a doula or a home visitor or something, like somewhere down the road, hopefully there's enough trust there that will be confided, and then the ability to help maybe was delayed compared to what it could be, but at least it's there. So that's the hope, but I think it's a good point.
Okay,
Tim?
if I go next.
Sure.
Thanks, Abby, for a great talk, and it's a great illustration of the positive relationship that can happen with research institutions with the state. And so thank you for all your work that you do. And I think you answered my question in part at the end where you talked about the value-based model, but I want to probe on that a little bit further. When I was looking at that box and whisker graph, and I want to ask you a little bit more about that. I know you have a lot of conversations with the MCOs at the high leadership level, and as this has kind of played out, have you had conversations to the extent that you can tell us about what they're looking at that data and they're like watching it and you're saying, look at this data, and are they sort of saying, you know, we're not doing as well as we should, and that narrowing of the box and whisker that you want to see happen, the state needs to see happen, we need to be doing better, and if you do, your dollars will go up, and maybe even there may be a little bit of a, not just a carrot, but a little bit of a stick at the end. And is the state thinking about that? There's a lot of my question, but.
That was several questions, I think. So the box and whisker plot was purely about kind of the time the mom first walks in the door, and someone fills out the NOP for her. So the MCOs have no control over that one. But I'm going to take a broader look at your question. Like, I think I will say, like, the different plans have very different personalities, institutional personalities, organizational personalities. I am confident that one of them at least is very much looking at these data and doing the kind of analytical work that you would like to think that people are doing. The other two probably need a little bit more nudging and poking, because they still want the data for the one, like the case management conversations, like that's still their primary interest. And I think we need to get to the point where they understand the power of the data as a set. And it's funny, I was planning to touch base with each of them separately and kind of ask them where they are with this. And then right then this other big monster of a task landed in my lap on rural health transformation. So I haven't done that, but I do want to do that maybe at the end of the year and just kind of touch base with them and say, so tell us how you've been using these data so far. And I don't know, I think there may have been another question in there, but okay, I'm going to move to Ben.
Hi, great talk. Lots of questions and thoughts, and obviously I have a background in this area as well. But so one, I had a thought and then a question or suggestion, I guess. Maybe when they're filling out the NOP form to increase the marking of the Z codes, once the zip code of the mom is entered, because that's entered first, maybe there's a way to like pop up a window or something on the side that says what the average rates of food insecurity and other issues are, sort of as a reminder to the person doing the data entry that in this area, these are the rates that are already known. Might be a way to sort of use some behavioral conditioning or whatever to let them know that it's not zero. And then the other question I had is, we're also in the middle of a congenital syphilis outbreak pandemic. I'm just wondering if the NOP could be used to confirm that they've had STI testing and what that might look like.
Yeah, there's somebody within MoHealthNet that has raised that point a couple of times. So it is kind of on our radar. And I know that, like, one of our struggles with getting this thing going was just the constant iterations that everybody wanted to make. So at some point we did sort of say, hard stop, like this is the form, we're going with this. But we also said, we're going to freeze it for 2025, and then we'll keep looking, and we may adjust and add things for future revisions of the form. So I actually just sent an email out last week to ask everybody, like, what do you think needs to be changed and added? And I think that's going to come back to the top as something that people would like to see. Either that, or maybe more along the lines of that C-star thing that I mentioned, where, if something's indicated, then you can look and see in claims potentially, although then there's a problem. Sometimes I'm not sure if the claims are accurate on that one. But definitely take your point and think about that. On the first one, our technology, our interface that we have for this is probably not the most sophisticated thing in the world. But I think that your larger point is definitely valid. I mean, I was just thinking about when I was snipping these maps, I was thinking to myself, like, I think it would be a valuable thing to just send people, like, here's the map we're seeing. Do you think it's accurate that 0 people in, this region have ever had a, certain kind of social problem? Because I think people look at that and they're like, well, no, like that's not what I'm seeing every day. So I do think we could do more with that in some form. So I appreciate the
And
comment.
just to clarify, they're not being, the other reason that they don't use the Z codes is they're not being reimbursed for them. So the NOP is different than the claims, right?
Well,
But
so what you're sending a claim in for is having conducted the SDOH screening.
okay.
And so it actually is, the logic is in the system that
Okay.
if you say that someone's screened positive for anything, you have to attach the Z codes. So it's trying to force it as much as it can be forced. Yeah. Matt?
This was really terrific, Abby. Thanks so much. Do you know, are any of the MCOs reassessing social needs after the notice of pregnancy form?
Yeah, it's ongoing, really. I mean, I think part of it, and somebody asked this, or I guess Morgan's comment was related that, especially after COVID, I think that the relationships between the MCOs, their case managers, and their counterparts at the provider practices were completely broken. Total lack of trust, lack of belief that anything was going to change if they reached out. And so part of the NOP has been trying to rebuild some of those relationships. And one of the um, stated rationales for doing that is that things change over the course of the pregnancy, and we're not asking people to resubmit a new NOP every time they notice something different. What we want is to establish the relationship at the beginning and then have an open line of communication so that as things change, that can be communicated. And like a related point is that all the MCOs have provider portals, which are places where that communication can happen, but they have really low uptake rate. And people don't know that that's available, or they don't know that, the OB provider of record does not have to be the one logging into it. Like it can be the CHW of the office that's doing that. And so that every time someone spots that there's something going on, there are multiple different ways that they can communicate that. But it's kind of the premise of this project is to start by saying, well, here's that initial snapshot. This is going to make the connection. And then, yes, we will continue to update. And there's a whole separate conversation to be had about postpartum, which I didn't even cover here. But circumstances definitely are likely to change during that period as well. And similar logic there. We do actually reimburse for doing another SDOH screening in the postpartum period. We don't have an NOP or a portal for that information, but a provider can conduct the screening and bill for it again at the postpartum visit. And then ideally, the relationship's already been established. The MCO can learn about it in any of the ways I just mentioned, and they should see the information on the claim. So that's kind of what we have.
I'm really glad we're office neighbors, because let's talk more about this.
Okay.
Because these social needs assessments have notoriously short shelf lives. And for many people, during just the course of a pregnancy, they would have a given social need, especially food, go up and be resolved and then rise again and be resolved, maybe, dozens of times.
Yeah.
So I worry, I guess, a little bit that if just linking people with a resource and a service is the outcome of interest, and I know it's not the only outcome, but it seems like it's what they're doing right now, that could miss the point.
Yeah, I think there's certainly more to be done here to refine this. Definitely. Well, thanks so much for your interest.